on the air. So, man, we're live now. Look at these three outstanding CIOs. One lives on the beach. He's got the great view. Two of them are kind of working at home.
He's a bum. Will's a bum.
He's a bum. I'm in my jam
He's
space.
a bum.
I'm in my jam
He's a
space,
bum.
by the way.
So we got Will Walders, Joel Vengco, Aaron Miri, all from different organizations. We were just talking behind the scenes. What were we talking about? Blacklist? Are we talking about vendor blacklist, or we kind of skipped that?
Yeah, that's what took 30 minutes. It's a long list.
So what's going on? Who wants to go first? What are some of the cool
friends.
things you're working on that you can share?
I vote for Will to go
You want
first.
Will to go first?
He's looking coolest.
Yeah, Will.
Yeah, he looks cool.
Yeah.
He's got the Rico Suave look going. So he's good.
It's a windblown look. Yeah. We just talked for 30 minutes. I think I'm out of stuff at this point. No, first I just want to thank all the healthcare workers, first responders, all the folks who are putting their lives in harm's way at the moment. Protecting strangers, doing the great work. So we can all sit here and joke for the past 30 minutes and catch up. And to include some IT staff. We've got about 30 folks. Frontline supporting folks in the OR, ED, and all these clinical settings. So for us, we've taken full advantage of the COVID being the number one reason for digital transformation right now. I was sharing with the group here. We went from single digits a week televisits to over 1,000 a day, implementing solutions around virtual waiting rooms, around digital front door, things that I'd hoped it would be on my 3-year roadmap when I got here about 9 months ago that are now happening today as a result of all of this. So, and learning more every day. I think the coolest thing we did to manage all this was stand up a digital task force that was empowered and enabled to make decisions quickly, take advantage of the vendor partners that are on the good list, not the bad list we were discussing earlier, to offer us some services and implement them in ways that just are mind-blowing at this point, really enabling our docs and other providers to just do the right thing. Thankfully here in Florida, at least our part, we're on the other side of that slope and starting to polish a lot of these things. We did the ready, fire, aim approach to some of that, so we're optimizing them now, and hope these things continue. In fact, we're not going to allow it not to. So we're really excited about these digital tools and being able to leverage them from here on out. So that's a lot of ways to say we're doing a lot of different cool things, but if anybody has some questions in the group, happy to go into some more granular detail.
Yeah, Will, I want to be like you, man. How do I be like Will? Let me ask that question. How can I be like you?
Aaron, we talked about this. You and I, we've known each other for a few years now and keep each other abreast. I think we've competed for the same jobs. I think if you'd applied here, you'd be leaned
I didn't compete with you. I didn't want to waste time. So,
That's a good one.
Against the balcony here, instead of me, and I'd be, who knows where I'd be, really.
You'd be in Austin. You'd probably be here. No, I'm kidding. It's all good. I'm happy for you, man. You guys are doing good stuff. You guys are really doing good stuff in Florida. It's good stuff.
Yeah, we're happy. We're excited.
Will's also doing some cool stuff in terms of getting grants. He's probably the most aggressive grant seeker that I've ever seen for a CIO. I mean, the first day the telemedicine proposal was out there for the stimulus money, Will texted me, "Hey, where's the whole requirements doc? I'm getting on it." I mean, he was really on it, just like Friday nights, sent a text out. So kudos to you, Will.
I tell you how I've survived in 22 years of government is finding money in places you wouldn't expect it, right? Yeah. So, and then it didn't hurt that at Walter Reed, all the senators and congressmen have a tendency to get care there. So, just go catch them in the hallway. So I wasn't bashful. Certainly won't be with this. And for the group out there, SCC has it. I think everybody knows about that. The USDA has one right now too, and as does HRSA. So there's a lot of money to be had out there to, for some of you, frankly, doubling, tripling your IT budgets from an innovation perspective. I know for us, we probably had about 10 million to play with this year for this kind of stuff. We dedicated 4 million specifically to digital tools, and we expect to almost at least increase that by 50% with the grant submissions we have. So excellent opportunity, as I mentioned, to get 2 or 3 years ahead of your digital transformation roadmap.
Yeah, that's actually a good point, Will. And the other thing is that AHA actually has some pretty good resources in addition to other groups that if you don't know what you're doing, do it that way. Question though, Will, did you already have an FCC ID? Did you already have a licensure number and everything to apply?
Yeah, so that it's not as hard as you think. Apparently we did. I just made another one. When I logged in, there were 6. And somebody somewhere in Health First history in 2015, so roughly 5 years ago, was working with the FCC for something. That person didn't exist anymore, so we just kind of hit the reset button. But don't let that intimidate you. I did it as a CIO in like 10 minutes. You get some smart people in finance or some of your admin staff, they can make that stuff sing. So yeah.
So did you get the grant? Did you get the award already, Will?
No, fingers crossed. We're still pending status.
Yeah.
I think we've all seen they've awarded 10-ish.
Yeah.
And I think that aggregates somewhere between 7 and 8 million. So that means there's another 192 million on the table. We've got roughly, hopefully we get $1 million of that, or 979 is what our grant was for. So
just right under. Yeah.
Yeah, 21K.
It's like his budget. He comes right under. Never goes over, just right under.
It's like you worked in government or something, Will. You kind of up to the game.
A little bit. We had some great partners, great grant writers, and another EVP here that also spent some time in government. Great colleague of mine. So we had a loaded deck when it came to this kind of work. So I'm very happy.
That's good, man.
Yeah.
Awesome.
No, I totally agree with what you were saying in terms of what how digital tools and IT has played a role in this this epidemic. I think one of the things that we've been fortunate to have is really a good foundational sort of operational platform, and then we were also looking at the horizon with our innovation work, and so those two channels enabled us to really sort of progress throughout this this crisis in such a way where we're firefighting as like everybody else is doing, but then you're also looking at least in this case 2 weeks, 3 weeks out, and having a team that's really driving both, right, sort of the today, making decisions for today, and then also looking at literally the tomorrow, because everybody's so focused on what's going on right now and trying to get workers off site. They're trying to get virtual visits online. We're trying to get analytics made available to folks, and then at the same time you're training everybody because they've never adopted these things, because it's like the first time they're seeing this, even though you've been talking about it for several years, right? But literally everything is sort of crashed down, on the today, and it's actually really remarkable the way that folks have adopted it. And I think they never really had an idea that they could do it so quickly, and here we are, and it's been really quite fascinating to see how folks have changed just the culture ultimately. And I think what you're saying is really something that's what we're thinking about now is how do we persist many of these things going forward. One of the things that we're going to choose to move forward with, one of the things that we're going to perhaps not do anymore, sort of the traditions that we've done in the past, and then how do we make that change? Because we have this question in our post-pandemic planning group. It's like, all right, so how are we going to look in this new kind of hybrid world after this is sort of flattened out a bit? And I think there's a part of the population that's thinking we're going to go back to how we were. And I think the reality is that we're not, because the patients are not going to want to be in crowded waiting rooms, and they're certainly not going to want to see other patients who they're not sure that are COVID positive. So there's going to be a lot of realities coming to term here that we're going to have to deal with, and I think business as usual is not going to be possible. It's going to be a very different landscape, and we have to be prepared for it. And I think CIOs across the country are going to have to be the ones that are leading, at the very least, the thinking around how do we do things differently. And if you don't, I'll tell you what, the competitors that are the non-traditional competitors are going to come in and take your lunch. So
yeah, Bright Health, Oscar, all those folks. If you expect anyone to sit in a waiting room ever again, I mean, I'd be very surprised, right? We're doing virtual waiting rooms, wait in your car, let us text you. And then why would you? I mean, right. This is now eye-opening for a lot of folks. I'm writing an article, I'll spoil a little bit of it now. It's like the 7 W's of recovery, right? It changes the way we work, changes the way we worship, how we work out, how we wine and dine, how we do wealth. Nothing will be the same again. I hope this disrupts the real estate industry. That's probably the most frustrated sector I have. I think it's still stuck in the
it's not a W, so it probably doesn't get disrupted unless you.
That's right.
Well, when you live on the beach like Will does, the real estate doesn't get affected too much.
Everything's a beach in Florida. This is a dime a dozen in these places. So. But
Aaron,
Joel's spot on there, right?
Yeah.
Hey, Aaron, show everybody your mask. Can you show everybody your mask? I think that's the coolest thing ever.
Yeah.
Yeah. This is my Halloween costume for this year, right? And so to the degree of it, we have a 3D printed N95 quality mask. Right? It's a seal on the side. You can hear me just fine. And you get the filter on the front here. There's no air leaking out here. you got a valve here for any condensation that comes out. And the cool thing is, if you do this, right, the filter is on the inside. It's going to replace the filter, between shifts or whatever else. And this is totally reusable. As you guys know, N95 masks are throw them away, right? This one you don't have to. This one can be autoclaved and whatever else. And so the cool thing about it was that, we take a 3D image of my face, and it's actually designed for my face, right? And so even has let's see here, you can tell, initials on the side here, so everybody knows it's yours. The way we're doing is we're printing up 3 for each clinician, right? So 1 for COVID positive or suspected, 1 for non-COVID, and then 1 is a hot spare. And so through a whole shift, 8, 12 hours or whatever, they wear it, good to go. And, again, you can't call something an N95 without FDA approval, but this is about to spec as you can possibly do. We went through every fit test you can possibly imagine between saccharin, Bitrix, blood, every kind of test. I had surgeons wear it a full shift. I've had perfusionists, RTs wear it a full shift. And even in a pediatric and adult setting, I didn't have any problems and loved it. So, for all my phenomenal legal and compliance friends watching, you've got to say this is not an N95, wear an N95. But if you don't have an N95 and all you have is a normal filtered mask, why when you can do this, right? So we're printing them right now for UT Health Austin. We're printing them in batches of 50 right now. We should scale up to a couple hundred a day here as we get better at the process. And so I should have my entire workforce essentially covered probably middle of next week. We're going to print the whole week and then into the weekend and the next week, but I should be done. And then feedback from a couple hundred clinicians will tell me a lot, in which case then we can mass scale and share this to the world. And so the whole point was, why are we suffering this PPE issue when there's great 3D printers and there's great ingenuity at UT Austin and we can fix this problem? So we did, and then we patented it. So
that's awesome. So Ray Lowe's on LinkedIn, he's asking how can he get one? Because LA is pretty bad. I mean, because I have family in LA, I hear what's going on in all the hospitals. They cannot get anything. So Ray's trying to figure out how can you get it.
So full commitment. I will be publishing. So a couple things. Obviously, UT Austin can't print these for the world. So I partnered with a commercial printer company in Austin that I will link out to, so that for anybody who doesn't have the capability, they have global facilities. They'll do it at cost, material cost only. So they're kind of doing this as a way to contribute back. But this is what they do: is they 3D print like industrial stuff, like military grade stuff. You'd be amazed at how much the military uses 3D printing, by the way. I didn't realize this until this whole situation. I'm sure, Will, you knew this. So they do this stuff in general. So I said, okay, can you guys be my distribution center globally? And if you do have 3D printers, fine, I'll send you the files and the instructions on how to assemble and just print them, right? So just all you gotta do is source the resin at that point and you're good to go. So give me the week to get the feedback collectively of a couple hundred clinicians to make sure there's no gotchas. And then in mass printing, there's nothing that comes up, because again, when you're printing a couple of dozen versus a couple of hundred, you're going to learn things, right? So just give me the week to get feedback, and the whole world can have access to this. This wasn't designed for making a profit. This wasn't designed for any other reason other than solve this PPE issue, because I'm sick and tired of hearing about it. We can solve this problem.
And Aaron, talk about the cleaning of it and how many either autoclaves or actual cleansings can it go through?
Yeah, so we've thrown it into autoclaves as well as also dishwashers. We've done about 30 cycles back to back to back to back, and there's been no issue with the material or whatever else. I'm sure it'd go a couple of hundred without a problem. I mean, this thing is pretty sturdy, and it's hard to tell on the camera, but it's pretty flexible as well, deliberately, right? But I mean, this is not going to break. It's better, in my opinion, and what the surgeons have told me, because the surgeon's opinion matters most, as we all know, but this is better than a traditional N95. And what's also interesting is that if you talk to surgeons, there are clinicians who can't wear an N95. They just cannot achieve the suction you need, because they're kind of small, medium, large. This one, because it is 3D, as it takes a 3D image of your face, this is actually my face, right? So it is made for the contours of my face. So everybody should have a more personalized version of an N95. Why are we wasting effort on all this stuff that we're doing? We just print these ourselves and be done with it, right? So again, by the end of the week, I'll publish it out. David, I'll share that link with you if you want to share with your links in the world. This was meant to solve a problem, not meant for any other reason than that. So
that's awesome. The face size is
that's great,
a big deal. So no, I'm glad, because I know a lot of folks who have smaller face. I mean, this mask will fit my big face fine, but the smaller folks, it's really hard. They cannot wear those masks, if you said. So, great point.
Right.
We start
some data points. It takes about 20 to 30 seconds on average to scan your. to scan your face, right? So figure 20, 30 seconds. We did come up with sort of a law of averages, like, okay, if you really don't have time to take a 3D scan of faces, can we come up with a small, medium, large that actually makes sense? So we do have that as availability, but take the darn photo of the face of the clinicians. They'll appreciate it. It'll matter. It's all secure. We worked with Microsoft, the HoloLens division, to be able to do the whole facial matching thing. So everything is secured. As you can imagine, it's bulletproof. You know, I'm a public institution being UT Austin, so believe me, there were no skirting around the rules, even though I wanted to go fast. So it'll be self-explanatory.
It's awesome.
Great. It's great.
Yeah.
All right. One last question before we jump off. Go ahead. Go ahead.
No, I was going to say this. The other thing I would say to everybody listening, make sure you partner with your local public health authority. No matter what institution you're in, call them up. They need help. They need your assistance, especially, you know, if you're leading any kind of size organization. I don't care if it's an FQHC or not. Go call them up. They need help. In our case, we were delegated authority to assist with contact tracing for certain public health authority here in Austin for certain populations. So, you know, we've launched a public health app with contact tracing, with home monitoring. We launched an AI chatbot, so the bot kind of does a self-screening for you. I mean, there's a zillion things that you can probably do that your public health authority just doesn't have resources to, and that's what we're here for. It's make a difference.
So speaking of this public tracing stuff, all the major tech vendors are making a play. You guys are making a play in your organizations. So do you foresee like 50 different public tracing apps for every state, or do you think we could get down to at least 2 or 3, or I don't think we get to 1, but what are your thoughts about that?
I got to tell you, I think the first piece is just operationalizing this. I mean, you know, here in Massachusetts, they're thinking 1,000 people have to be hired to do contact tracing, and that's ridiculous. So there's got to be a way to do this at higher scale, larger scale, without having that many bodies doing it. So I think there's a first level of just trying to figure out how to do contact tracing, in this day and age. So. Part of what we're trying to do is understand whether we can leverage our health information exchange to be at least a foundation for that. And if we can get other organizations to connect to it and figure out ways to use that as the repository, that may be at least the first part of the foundation. But, we have to solve the problem of figuring out how to really either interview folks more naturally or more efficiently, and then figure out how to sort of collect that data over time. But I think the old ways of doing contact tracing are just not going to be valid, and so that's the first hurdle I think we got to figure out.
That's a good point. Will, what about you?
Yeah, we've been lucky here. I'll knock on wood. We're treating it like any other infectious disease. We've had 500 cases in the county. We're somewhat isolated by beach to the east, swamp to the west, and great land masses of both to the north and south before you get to Jacksonville and Miami, respectively. So our traditional way of infectious disease and there's some great tools there that do that. Now, to my peers who are in metropolises such as Austin and Western Mass, just bordering on Boston there. Austin and Boston, it's funny, the twins there. They've got a bigger burden, but our plan notionally is to treat it as such. I'm more worried about screening, thermal screening of every person that has to come into one of our 140 plus buildings at the moment. So that's keeping me up at night.
Good point. And anything else, Aaron?
Yeah, I would say this. For those of you that have a medical school or you're tethered to university, in my case, UT Austin, we're also integral as part of the process to come back to the university, right? So many students, we had to transition all of our med school and all of our classes online, that was interesting, right? But after that, now how do you reintegrate them back for the fall? Look at that, right? That because part and parcel of that was contact tracing. You have to do that. You have to understand who these people have come in contact with. There was a very public news article that ran about a couple of weeks ago with some wonderful UT undergrad students who chartered the plane to Cabo, who all came back pretty much a large predominant part of them positive. So kids will do what kids do, and you have to contact trace to understand what that risk is to the community, and more importantly, minimize the risk to the faculty and to the staff there at the university. But to the degree of it, anything you can do to get in the middle of this. David, to answer your question, will there be 50 or 60 apps now? That won't happen. What will happen are exactly what Joel's saying, some principles and some fundamentals. Contact tracing has been around for a long time, right? People did it on Excel, people did it on a notepad. Just now, people are like, oh, Bluetooth. But that comes with a litany of privacy and other things you got to work through. And so unless we are adopting a philosophy like China did, which made it completely mandatory, South Korea made it mandatory, unless we take that approach in this country, which I don't think the states will get aligned to do that, it's going to be difficult to make it a one-stop shop. But the principles will get better, and technology will definitely accelerate it. But I don't think it's going to be the one-stop shop end all. But you won't see an epic systems of contact tracing, put it that way.
Yeah. No, I agree
Hey, Dave,
with that.
I got to roll to another meeting, so I apologize. I got to prep for it in 10 minutes. So,
Yeah, I think
gentlemen,
we're done too.
yeah,
You
great
clearly
to see
got
you
to
all.
jam out, Joel. I see the drum set behind you, man. Don't lie.
I know.
You're doing,
Raylo
man.
is
You
like
can
pick
jam
up an
out.
instrument. Raylo is like pick up an
Sure,
instrument. You know what?
man.
Next time I'll do that. That's not my drum
right.
set. That's my kid's drum set.
You're
Yeah,
trying to be the
good,
manager.
by the way. Your daughters are excellent, by the way. Excellent,
Thank you.
excellent,
Thank you.
excellent. So
Thank you. All right, gents.
Yeah.
We'll see ya.
All right, I think we're
Thank
done
you,
as
sir.
well. Will's got to get out the beach because he's not practicing social distancing.
No, there's no one here. You haven't seen anyone. There's no
Will,
one within 6 feet of me. I'm good.
yeah, I think I see a tsunami back there, brother. So you better run.
Yeah, yeah. But that's
be the
all the
best-
time we
best
got
way to
today.
go
Aaron
right
and I have
now.
to go back to our kids, but it
Cheers.
was fun.
Cheers.
Great catching up. We'll
Welcome.
talk more. All right, later, guys.
Bye, guys.
See it.